neuromuscular disorders. I just had to get something figured out with like my microphone, as freaking usual. Okay. But now we don't have to worry about that anymore. Now it should sound really good. Anyway, neuromuscular disorders. Any disease that affects the peripheral nervous system, okay? Peripheral, not central, okay? Central nervous system issues involve the brainstem and the actual brain itself, the cerebellum, medulla, whatever, okay? That is what that is. Brainstem, cerebellum, medulla, cerebrum, okay, whatever. That's the central nervous system. The peripheral nervous system is essentially everything else. All the nerves that innervate your hands, your legs, your organs, your skin, whatever, okay? I mean, you could even say your face, right? All those peripheral nerves. Now, if you've got an issue with those, it's not your brain that's going to be affected necessarily, okay? There might be a part of your brain that causes the issue, but you'll still be able to think, you'll still be able to have all of the necessary central nerve system things that cause your body to be able to continue wanting to breathe. But when it comes to your muscular systems or your muscles' ability to do things, that's where it could be affected. That's what neuromuscular issues, that's what they're usually going to be caused by. It's an issue that affects the peripheral nervous system. Now, where it's coming from, it could be a lot of different things. But ultimately, the problem comes from, the issue is that your peripheral nerve system can't do what the central nerve system essentially wants it to do. Muscle weakness is the predominant condition, okay? And that weakness is not just because you need to go to the gym, okay? That's not what that even means. It essentially means that there's not enough of a there's not enough nerve power. I want to look that up, okay? Why can't I move my muscles? Pathophysiology of in neuromuscular disorder. Disruptions in communications leading to all of that, a more detailed explanation. It happens at the neuromuscular junction, where nerve signals are transmitted, causing them to contract. In some disorders, the transmission of these signals is blocked or impaired, preventing muscles from contracting properly, as in myasthenia gravis, which we'll learn about, but not in this specific PowerPoint. It can also be caused by nerve damage, such as in ALS. So there's a lot of reasons why your nerves might not be able to do what they need to do. But ultimately it comes down to either the nerve signals can't really get there, or the nerves that get the signals can't really do anything with them. They get the signal and they're like, we just don't have the power that we used to have. I'm sorry, we're not strong enough. Anyway, and that brings us to a discussion on the neuron. Wow, neurons. I love neurons. They are kind of complicated, but really not. We'll talk though about how neurons work. Okay? How do neurons work? Okay? So, neurons are I like to think of them as like a you know how when you are they're like an extension cord, okay? Kind of. And the nerves in your brain are all just this big long connection of this whole long extension cord where they connect would then be called the synapse, perhaps, where all of the electrical signals that are created by your brain then travel through, okay? So, what happens in a neuron firing is that the electrical impulse kind of it shoots across as it is. Yeah, it starts somewhere, okay, traveling down the dendrites. Those are these little thingies right here, okay, into the cell, like through that whole area of like the cell body and the nucleus of the neuron, and then down through the axon, where then this axon has these like padded sheaths around it called the myelin sheath that help keep that electrical signal in there and not have it like zap out and escape and all over the place. That's foreshadowing. Okay. And this, then it travels through the axon, and it gets to the synapse of the next neuron where that whole process happens again. Okay. That's like the bare bones baby basics way that we connect electrical like action in our brain. Yay, woohoo. So that's really what it happens. Now here at the synapse there's these things called neurotransmitters, okay? Now the thing that initially caused that it's not like the electricity itself necessarily like is going across, kind of. Like, maybe you could say that it is, but most likely, and what people have decided, basically, is that we have these things called neurotransmitters, and it's scientifically proven. I don't know why I'm saying it like it's an opinion. Neurotransmitters. They're sitting here at the top of the area between the synapse and the next neuron. So you could say the synapse and whatever. Their next cell. Dendrites, whatever, okay? So this synapse has neurotransmitters that essentially send that same message from this cell to here. So those neurotransmitters say, yep, we got the message, we'll keep on sending the message down, like a more advanced game of telephone, okay? And so, except that they're right and they don't make up stuff in the middle. Hey, guys, telephone, the point is to keep the same message. Not just say, like, something about some sort of part of genitalia and pretend like it's really funny. Hey. Anyway, that's way off the point. What the point is that if there's an issue here at the synapse, then it doesn't matter how well this area works, okay? It doesn't matter how well we conducted it. If there's an issue at that synaptic gap, then the signal won't really be effectively transmitted. Okay. Now you can see that there's multiple different synapses here, so it's not like there won't, at least at first, it's not like there won't be any sort of message sent. But if there's not enough neurotransmitters, it's just gonna be a less strong sort of deal. Okay. And this is important. Action potential. When a neuron receives strong enough stimulation from other neurons, it triggers an action potential, okay? I want to see, do neurotransmitters, guys, I spelled transmitters wrong. Do neurotransmitters, affect action potentials? Yes, they do. They literally are the action potential. Hey, guys. So, the more of these neurotransmitters that are sitting here at the bottom means it affects the excitability of the cell. There's good graphs about how action potential works. And I can't really find any of them. Oh, here's a good one. So the whole point is that there's this whole idea that a cell has to be stimulated above a certain threshold, okay, in order to fire, okay? So here you can see that this like place right here is resting. The neuron isn't doing anything, okay? So, as different excitatory things happen, the amount of excitation increases. And it has to pass over this hump, okay? this hump essentially, and this line, is the amount of stimulation that it takes to tell your neuron, hey, this isn't just like just some sort of accidental like message. This is real. We need to do something about this, right? So once the amount of stimulation passes this level of this threshold of excitation, that's where we see an action potential, okay? Which is the potential for the nerve to go, oh, okay, yeah, let's do something and send something through, or do something, or catch something, whatever, blah, blah, blah. So it sends through that thing, it sends that deal through, and then it has to go through a depolarization, or a repolarization period, okay? It depolarizes, which means it shoots off its message, and then right afterwards it goes back to resting. It goes actually below resting potential, okay? Or that resting membrane thing. That is because we don't want this to just constantly be shooting stuff. That's a bad idea, okay? I mean, that's where you have this membrane that can't stop. It can't stop. It can't gain back whatever it needs to fire off the next pulse. I mean, we need it to be able to rest. So it goes down below the resting membrane potential as far as polarization is concerned. Here they have this -70 number. And once it goes down below that, once it's ready to basically fire again, it'll go back to the normal resting membrane potential. Here, it's called resting membrane potential because while you're there, there's a potential for excitation, okay? Yay! There's also a potential for inhibition, okay? But that's another thing. When it comes to neurotransmitters, the point is the more of them they have, the more of a chance for the action potential, or for the actual telephone message of what this neuron to the next to go through and pass on to the next one, okay? And this all happens like in a span of microseconds, okay? So quickly. Every word I've said has been an action potential that's somehow gotten through. We should have stopped them. We should have been like, no more of this. Anyway. So what is multiple sclerosis? Like, remember that myelin sheath? Okay. So there's a lot of different places where things can go wrong in the the neuron, okay? Because it has a lot of these things here that help to get this electronic potential or whatever through here to here. They've got to pass through this long freaking sheath or this long axon, right? And the myelin sheath is meant to keep them there, okay? The myelin sheath is like a what's the freaking word? Like an insulator, keeping the nerve impulse from scattering all over the freaking place. The neuron sheath, it's like this, I think it's kind of like this, I wouldn't call it like fatty in the way that you think about it, but it's made out of that same components. And so it helps to insulate and keep that electrical charge inside of there, okay? Now, in multiple sclerosis, MS4, myelin sheath. Hey guys, we just figured out a new way to remember something. Can we remember that? MS for myelin sheath, okay? In MS, the myelin sheath degrades, okay? Now what can cause that? I don't know. I mean, let's look it up. Let's see if somebody knows. It's unknown. Hey, cool. I'm glad no one else knows. That's so funny. They say it's 2 times more likely in women and Caucasians, okay, which means that there's probably a genetic factor, which is what they say here. They also say that exposure to, like, the Epstein-Barr virus, smoking, and low levels of vitamin D can play a role. Hey, you're probably right. And of course, if your immune system decides one day that it doesn't like anything in your body, you're going to have some sort of issue. And autoimmune issues, they're always part of, they're a huge bummer, because it's like, that's your body wanting to hurt itself, basically. Dang, that's rough, dude. Anyway, so in MS, this myelin sheath begins to degrade, either because of your genetics, because of your immune system, or because of some sort of environmental factor like smoking. I don't know, could happen. Now, what happens is when this dendrite tries to send a electrical charge through the axon, a damaged myelin sheath has the potential for some of that stuff to spark out, okay? Leading to issues where stuff can't really get to the synapses. And you've got that neuromuscular issue, okay? It's a demyelinating disease. Now, multiple sclerosis is an autoimmune, progressive, degenerative. So autoimmune means that it's, here we're using the idea that, okay, your body is targeting the myelin sheath. Your body is eating it away, okay? Progressive, which means it just gets worse forever. It's degenerative, yep, gets worse. Progressive, it goes on for a long time. Degenerative, it gets worse. Inflammatory disease of the central nervous system. Hold on, I thought you said that this is the progressive of the peripheral nervous system. Hey, we're getting there, okay? We're freaking getting there, okay? How does MS cross blood-brain barrier? What the crap does that even mean? Multiple sclerosis, immune cells bypass the blood-brain barrier. Oh. Okay, so the blood-brain barrier usually is supposed to keep the immune system out of here, and unfortunately, it's become compromised. And then the immune cells are like, finally, we got in. And they start eating the myelin sheath. Bro, sometimes I'm like, guys, could we turn off the immune system? And that's what they do. But let's move on from that, okay? So, types of MS. They said it has periods of remissions and exacerbations. And we'll kind of talk about this in a second, but there's 4 types of MS. We don't really need to necessarily know them, but it does help to know like what MS can look like in different people, because MS can look like a bunch of different things depending on which kind of type of MS the person has. So relapsing remitting is that you'll have periods of basically being okay, and then you'll have a really bad relapse where this symptoms of MS happens, and we'll talk about what those look like in a second. Back to kind of baseline, and then back up, and then baseline, and then back up, okay? Gets worse, then it gets better, then it gets worse. Well, gets worse, gets better, kind of goes back to being bad, gets kind of back to being bad, but it always goes back to baseline, which is good. I mean, I'd rather have it go back to baseline, okay? Because you can still, at least you have that baseline level of function, gets worse, baseline level of function, gets worse, baseline level. So you're always going back to that baseline. In primary progressive, right, so that was relapsing remitting. Primary progressive, it just simply gets worse and worse and worse and worse forever. It never goes back to baseline, which sucks. That's not good. Secondary progressive looks a little bit like relapsing remitting, except it gets worse, kind of goes back to baseline, gets worse, and then you don't really get back to baseline. You sort of are only, your baseline sort of shifts up to being kind of worse, and then it gets worse again, and then once again your baseline function decreases. So kind of normal, goes up. Yeah, so it just gets worse progressively. But there are periods where it gets really bad and it comes back to a baseline, right? The baseline just keeps on getting worse. And then in progressive relapsing, it's constantly getting worse, and then you have a really bad flare-up, and then you just keep on getting worse. Yeah, anyway. So let's talk about what multiple sclerosis looks like before we talk about, well, they won't talk about it. Well, yeah, they will talk about it. What happens with multiple sclerosis, and we'll look into that deeper, okay? But for right now, we have to know exactly like what the whole deal is with multiple sclerosis, okay? Because here they're talking about GBS for basically the entire time. Yeah. So, multiple sclerosis, it's an autoimmune disorder, okay? Your myelin sheath don't just explode one day. Your immune system decides that you don't need your myelin sheath anymore, or that your myelin sheath, worse than that, it's like your myelin sheath. Don't you know the myelin sheath works for the government? It's a government scam. We have to kill it. It's crazy. You can get it diagnosed with an MRI, EMG, electromyelogram, which looks at your. I think that's what it's called. What is an EMG? I just said it wrong. Electromyography measures the electrical activity of your muscles and nerves. So, electromyography measures electrical activity of muscles and nerves, and you can get a lumbar puncture. Now, what will this lumbar puncture show? Well, it'll show that you have immunoglobulins and more myelin in your spinal fluid, basically. Hey, what are those immunoglobulins doing there? Oh, they're eating up my myelin. That's why we have the thing is, when your immune system is eating, it's really a messy eater. It goes in there, it shoves stuff in its mouth, crumbs are falling over the place. So when you look and see, if you try to look with some sort of diagnostic imaging to try and find out if your immune system has been doing anything right, even when it's eating good stuff like bacteria, you'll find like little bits and pieces of stuff that's elevated in the blood serum. So you're like, what the crap, was the immune system working here? Yeah, she's a messy eater. But you'll see elevated myelin in that lumbar puncture because it's a messy eater. Immunoglobulins are a messy eater. But they're there, and that's not really great. We don't like to see immunoglobulins in the spinal fluid. Hey guys, what the crap? Signs and symptoms. Now this is important. And I'll look up signs and symptoms of MS for more of a variation, because here there's literally two little points, LOL, but here they have sensory issues as being an early onset issue, okay? Now that early onset issue can look like a bunch of different things, but ultimately you're going to be seeing sensory changes first. Sensory issues are your first sign that something could maybe be wrong. So that could be, okay, what are the five senses? Touch, taste, smell, vision, smell, vision. Hold on, guys. Maybe I'm forgetting my five senses. Touch, taste, feeling, smelling, hearing. Guys. Touch, taste, feeling, smelling, hearing. Okay, good job. Touched, taste, feeling, smelling, hearing. Oh, thank goodness. Hey, when did I learn this? In kindergarten? Anyway, you have trouble with all those, okay? Early onset, you'll have sensory issues. That could look like double vision, not being able to smell suddenly, feeling kind of pins and needles on the tips of your fingers, trouble with balance, because our hearing has a big part to play with our sense of balance, okay? It has to do with the inner fluid of our ears and the freaking crystals in our ears. Yeah, it's kind of complicated. When you think about balance and hearing, it gets so complicated. And I'm not going to think about that right now because you know what? I am. What are the crystals? Look at that. Calcium carbonate crystals in the vestibular system. Crucial role in maintaining balance. Here's the thing. Do I remember things? I sure do. Do I remember things in a way that is useful, in that I can cite what they are, what they do? No. So I guess that makes my memory fairly useless, but at least I know what I'm talking about. Oh, that's so funny. Anyway, Yeah. Those are our sensory issues. And those will be early onset. Usually, I mean, unless you've never had this before and you're like, what's going on? When it comes to like a flare up, as considered from somebody with MS who has a flare up, these are issues that happen uh, maybe as a precursor and maybe throughout, but these aren't the worst issues that this person can get. And sensory issues. When you're thinking sensory issues, go through the 5 senses and say, what can go wrong? Double vision, blurry vision, feeling pins and needles, weird sensations like burning, weird not being able to smell, smelling things that you shouldn't be smelling, balance issues, trouble hearing, maybe some ringing in your ears, any sort of thing like that where you're like, that's weird. Why am I feeling this? Sensory issues are that's what they are, and they're usually a sign of a deeper issue. Okay, especially when it comes to MS. Now, they have here symptoms vary by person and depend on where the damage has occurred. There you go. I mean, it's not the same for everyone, of course, but there you go. So like here they say optic neuritis, which can happen via inflammation of the optic nerve. So somebody with MS who has an issue with their optic nerve, where the MS has hit those optic nerves and the myelin sheath there is being damaged, will have different sensory symptoms than somebody who, I don't know, has had their damage to the vestibular cochlear nerve. Okay, it totally depends. But at the end of the day, you can't look at somebody and say, oh, yes, you have damage to this nerve, unless you notice their symptoms, right? And everyone's symptoms are totally different. So symptoms are really important to keep an eye on, obviously, because, yeah. And honestly, at the end of the day, like, does it matter? Kind of. But more than likely, it matters what, like, you won't even know where to look unless you watch the symptoms. Whatever. Symptoms depend on the person. Depends on the situation, but they will have sensory issues. So you can go through all those 5 senses and say, are those involved? What's weird with them? There you go. When it comes to flare-ups, essentially consider all of these things, but worse. Another of the issues that can happen with MS are motor problems. Of course, it's a neuromuscular issue, where the fact that the myelin sheath can't conduct signals very well means that not a whole lot of stuff gets down to the peripheral nervous system. So you do have this progressive muscle weakness or stiffness where you might want to move, it's just that you can't, or it takes a lot of energy to do that. It takes a lot more energy than it should, because there's a baseline amount of energy that's just kind of being lost because the myelin sheath is gone. Kind of rough. So you'll have that muscle weakness, stiffness, which can cause clumsiness. You can get tremors or spasms or difficulty with fine motor skills. Yeah. And we'll talk about a little bit of that stuff. Flare. There it is. Fatigue, weakness, numbness, tingling, balance problems, vision changes. Why? Okay? So, yeah. Why does MS cause fatigue? Damage to the brain and spinal cords disrupt the normal more energy. Look at that. Look, I'm so freaking smart. I'm just kidding. I truly and really am not. I'm making this up as I go along. In a MS flare-up, which we'll kind of talk about a little bit, whatever symptoms they may have had, they will get kind of worse. Let's see. You're going to have fatigue for sure, and fatigue can be kind of a thing that happens throughout the person who has MS. Oh, sorry, I just hit the microphone. Because they already have to use a baseline excess of energy to send those nerve signals. They'll have muscle weakness, which makes it hard to perform tasks because they don't have as many of those nerves that can help to fire things. Numbness and tingling because of those sensory disturbances, belly problems, of course, based on that weakness, but also because of the sensory issues. Vision changes, yes. Cognitive difficulties. Now, this is where this one differentiates from a lot of our other neuromuscular disorders. This is a CNS problem. The myelin sheath in the CNS, because I believe, I don't think the peripheral nervous system has a myelin sheath. I want to check that. Yes, it does. Hey guys, and I take it all back, I'm pretty stupid. So they do all have myelin sheaths. I think there's something that doesn't, but I'm not really sure. Schwann cells. Oligodendrites in the central nervous system are okay, so the myelin sheath is just made up of different things. Okay, that's fine. The myelin sheath is formed by Schwann cells in the PNS, and in the CNS it's caused by oligodendrites. Hey, that's cool. At the end of the day, though, they're both a myelin sheath. How fun. Okay, anyway. So, but in the CNS, if that myelin sheath degeneration has been caused by there, and it crosses the blood-brain barrier, we can get in there and start eating up that damaged myelin sheath. You can have that brain fog, because now you are affecting the central nervous system and not just the peripheral nervous system. Dun, dun, dun. So what does treatment look like for somebody with MS? Okay. The big one is suppressing and regulating the immune system, because remember, this is an autoimmune problem. Our immune system has crossed the blood-brain barrier and has started to run rampant, eating up our myelin sheath for some freaking reason. So, in the case that you have something like an immunomodulator or immunosuppressant, you can suppress the immune system, which hopefully will help your immune system to be too tired to want to eat up your myelin sheath. The only issue with immune system modulators and suppressors is, of course, that the reason we have it is so that you can detect and destroy infections. And if you can't, then your ability to fight off infections goes way down, okay? And infections are not good for you. In fact, they can kind of kill you if you just let them run rampant. So risk for infections. And a lot of the signs and symptoms of infections are not caused by the infection themselves. Like fever. Fever is an immune system thing. The fever is not caused by the bacteria. It's not caused by the virus or the parasite or whatever. It's caused by your body seeing that thing and going, what the crap? Hey, get this out of here, by the way. Yeah. So consider that. Look for subtle signs. And I do like this one. Skyrizi. Skyrizi. Rizzy with an I. Used for plaque psoriasis, active psoriatic arthritis, moderate to severe Crohn's disease, and ulcerative colitis. It's just an immunomodulator. It's not one that we need to know. It's just a funny one. A funny one. It's just funny and silly because it's got Riz in it. Anyway. So, multiple sclerosis. This is a big page of a lot of different things that we probably should know about MS. And about the treatments and about why the treatments are here and all that. So, for multiple sclerosis, the point of the treatment, as far as the immunosuppressants go, are to suppress/regulate the immune system. What can we do to suppress/regulate the immune system? We already talked about immunosuppressants, okay? Corticosteroids work fast. When you need to quickly turn off the immune system, say, we don't really need you right now, please go away, corticosteroids work really great, okay? And you got to consider what kind of patient education you got to do for corticosteroids. do. La 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 la. They can cause a lot of issues with like feeling hungry or feeling not hungry. Can make you feel terrible. It can give you a lot of mood swings. It might increase your body hair. It just kind of messes with a bit of your hormones. They won't like necessarily kill you, but there are some bad conditions that can happen with corticosteroids. They raise your blood glucose, which if you've got sort of a history of diabetes, you have to be considerate of. It can give you Cushing's syndrome, which increases is caused by too much cortisol. And cortisol is a stress hormone. Cortisol is released, I believe it's released by your adrenal cortex. Adrenal glands. Yeehaw. Of course. It helps body cope with stress by increasing the blood sugar levels and suppressing the immune system. Well. And why are they called corticosteroids? How are they called corticosteroids? Okay, because they mess with your adrenal glands, which release cortisol. Oh my goodness, this is actually crazy. What? So you might experience mood swings because essentially your body is going into a stress reaction in order to keep you from... Oh, that's so crazy. That is so crazy. Is that why, like, after you've been stressed for a long time, you get sick? Because when you stop being stressed, your immune system kicks back in and says, hey, what the crap did we just let happen? That's so interesting, bro. Anyway, that's the fast-acting immunosuppressant. It works very quickly. Long term, though, a person with MS may get azathioprine, or called Imuran, which takes 6 to 8 weeks to see effect. Yeah, that's like, 2.5 months, maybe, to see it. So somebody who's taking azathioprine or interferon B, well, at least Imuran, azathioprine. Dang. Multiple sclerosis, azathioprine. If they are like, hey, I've been taking this and I've still got these issues, yeah, it'll take 6 to 8 weeks for you to see any sort of effect. Nobody likes to hear that, but unfortunately, it's the way that it works. And this person might also get interferon B or beta-serone. I want to make sure. Beta-serone time to work. Shoot, but you might not notice it working. Okay. To see improvement. I don't know. Might not notice it working. Okay. Start. Seeing results. I hate cookies. You know what? Screw this. Go away. And yeah, with all of these, watch for infections. Because guess what? Infections can cause MS flare-ups. Even if you're taking these immunosuppressants, when you have the infection, it can cause a flare-up, even if you don't realize that you're infected. Because you could have that suppressed immune system, everything is working perfectly fine, and then boom. Oh, then boom. Now you have a flare-up, and now things are getting worse. Flare-ups are really bad, by the way. Imagine all the things we talked about as far as the MS issues, and imagine them, they all get worse. Flare-ups can be life-threatening when it comes to MS, because when you've got that, it's like extreme muscular weakness issues, where now it could be affecting your ability to breathe, like your ability to use your diaphragm to start working, which is not good. I don't want that. You don't want that. Anyway, immunomodulators, another one that helps to suppress the immune system, except that it modulates it. Fungolimide, or Galena. This is a PO med, which is kind of nice, but it can cause a blood pressure problem. It's been a while since it can cause both high blood pressure and increased blood pressure sustain. Oh, okay. So it increases blood pressure. So fungolimod can increase your blood pressure. So with somebody with hypertension, you want to be really watching that, monitor that blood pressure. Obviously, if it goes up crazy, you want to tell somebody. Yeah. And having that high blood pressure, listen, I'm no genius, okay? Can a very high blood pressure set off MS flare? I'm sure it can. Yep. Can potentially contribute or worsen MS symptoms and increase the risk of relapses or disability progression. Chill. Okay. But just things to keep in mind. We have a new immunomodulator called ozanimod, which can apparently cause cardiac arrhythmias. Can cause problems. Yeah. So, another thing to consider with immunomodulators, okay? This is very important. With immunomodulators, there's this thing that can happen where it changes the immune system, it suppresses it, whatever. There's this opportunistic disease called PML, progressive multifocal leukoencephalopathy, okay? PML. Which is a rare, progressive, fatal brain infection that damages the white matter of the brain. Also the myelin. Yeehaw. So, yeah. No cure, but treatments can help slow progression and improve symptoms, like immunomodulating therapies. Oh no! Anyway, so that's just one thing you have to think about, is if that person is on immunomodulators, you got to consider that there's a chance that there's this risk for progressive multifocal leukoencephalopathy that can kind of pop in. Okay? Hell, to prevent exacerbations, you want to avoid stressors. You can't avoid all of the stress that could possibly happen in your life. Unfortunately, that's not a thing that exists. But there are aspects of your environment that if you can avoid, you probably should. Extreme hot or cold, those are stressors. Those force your neurons to use more energy to say, hey, how do we get out of this? And of course, that can cause issues. So that's avoiding internal or external stimuli like hot tubs, really, really stressful environments. If you're going out at like 105-degree weather at noon, hey, maybe don't do that. Maybe stay inside if you can, if you possibly can. If you can't, I don't know, get a parasol or something. So, little things like that. And of course, if you're sick, you want to make sure you stay on top of that. You don't want to you don't want to really get sick. I mean, if you can possibly help taking good care of yourself and doing the things you need to do to stay well, that's what you should be doing. Symptomatic care. This person might experience muscle spasms, okay? Because they have MS, they may get muscle spasms. You can give them baclofen, also known as Lioresal. Lioresal. That makes freaking sense. Lioresal or baclofen. Those are great for muscle spasms. Baclofen, Lioresal, muscle spasms. One thing you gotta keep out for with baclofen or Lioresal is they can cause hallucinations. What the crap, dude? Yeah, they can cause those, and obviously if they're getting hallucinations, they don't get it anymore. Hey, sorry. You've lost your baclofen privileges because you started seeing ghosts. Oh, that's kind of funny. That's a little silly. Tremors, you would be giving them anticonvulsants to help stop the tremors, such as carbamazepine, Tegretol. Hey, I got that one. Hey, we got Tegretol, the anticonvulsant, carbamazepine. Carbamazepine for anticonvulsants. Yeah, freaking ha. And then they may also have constipation. Because guess what? Hey, this sounds crazy, but you know, your smooth muscle is also innervated. So it's also taking your body extra energy to make sure that you keep on pooping. Laxatives. Now, I love how I put here, you need psychological care for intimacy issues. Because, it's not like the act of copulation causes you to, burn energy or whatever. Yeah, no, it can cause muscle spasms. It's really awkward. So, psychological care. Hey, buddy, you can't bang your wife anymore because you have MS. No! Yeah, I know. Me too. And then education for safety. Yeah, this person is kind of at a risk for falls. If they are having a flare-up or if their baseline has become, pretty unstable. That's kind of a person-to-person thing, but definitely during a flare-up, you want to make sure that they're staying safe. No falls. If they're having, any sort of, muscle spasms, you want to make sure that maybe there's no, freaking pointy, sharp parts of the bed that they could whack their hand on. Hey, just things to think about. Preventing infections, of course. Duh. Because that can cause exacerbations. Boom. And it can also cause them to be hurt if they're on an immunosuppression. Even if they don't have a flare-up, if they're immunosuppressed, you would rather them not get an infection because that can cause other issues and damage to the surrounding tissues and blah, 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 kidney problems, liver trouble. Okay, that's it for MS, basically. That's basically it for MS. Of all the ones we're going to look at, MS is one of the only ones that really involves the central nervous system. The rest of them mostly affect the peripheral nervous system, mostly. I'm not gonna die on that hill because maybe I'm wrong, but as far as I can remember, and that's the thing with multiple sclerosis, right? It starts when you have those sensory issues, which can progress into flare-ups, where you have basically more issues with your muscle function and extreme fatigue and crazy imbalance and maybe even tremors and muscle spasms. You can also get that brain fog where you just are like, I feel really slow. I just don't even know what I'm doing right now. And that's all caused by the degeneration of the myelin sheath. Yeah, it comes in many different forms and functions. You can have the progressive remission type. You can have the remitting relapsing type. Blah 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 blah. But just things to think about in which ways that MS is kind of stands out on its own. Okay. Yeah. We're working our way through, okay, people? We've got only 20 slides left. I would really like to pause this and grab something to eat. But I can't. Okay? I can't do that. That's not something I can do right now. Unless I wanted to go into iMovie and put this together later. I'll have to wait to get my orange juice, bro. You're gonna have to wait. GBS. okay? Also known as Guillain-Barré syndrome. Whatever. Ascending paralysis. This is important. There are going to be so many random freaking neuromuscular diseases we have to learn for this test, okay? We have to know what makes them special and different from each other, okay? Okay. Now, MS starts in the central nervous system, okay? Eating up your oligodendrites, okay? Eating up your oligodendrites. GBS is a form of ascending paralysis. It's trouble starting at the lower extremities, your legs, that slowly rises. That's the biggest one, okay? Boom. It starts from your toes, moves up to your nose. Hey guys, that's a really good one. Hey, that's a really good one. I like that one. That's really cute and funny. It's caused by the destruction of myelin, known as demyelination. I'm mentioning that those are your swearing shoes. Alright, it's very similar to MS. It's an autoimmune disease, but it attacks the peripheral nervous system. Okay, guys, that's the difference. In MS, it's the oligodendrites in your CNS, okay? In GBS, it's your Schwann cells in your peripheral nervous system, because they both have myelin sheaths. They're just made up of different things. That's the important part. In MS, the globulins that are going in, they don't really care that much about your peripheral nervous system, because remember that myelin sheaths are made of two different types of cells, kind of. They both act as the myelin sheath. It's just that in the peripheral nervous system, they're called Schwann cells, and in the central nervous system, they're called oligodendrites. In MS, multiple sclerosis, those immuno cells are going, let's kill the oligodendrites. Let's kill them. No, don't do it. Please don't hurt me. That's what's going on, okay? In GBS, Schwann cells. Schwann's like, please don't hurt me. I'm just Schwann. Yeah, that's what's going on. GBS attacks the peripheral nervous system, starting from the toes up, okay? It is more common in adults and males, most commonly seen from people that are recovering from viral illnesses, such as the flu or the Epstein-Barr virus. Hey, why is the Epstein-Barr virus so annoying? Why is the Epstein-Barr virus causing so many problems? It is highly contagious, establishes lifelong latent infections, and linked to various diseases, including mononucleosis and certain cancers. Why does it cause that? Well, does it just affect your cells? May trigger and exacerbate autoimmune conditions like multiple sclerosis, blah, blah, blah. Interfere with the immune system, receive to present antigens, prevent potentially evading immune responses and contributing, blah, blah, blah. By specific locations, potentially activating genes that contribute to disease. That sucks. Anyway, myelin sheath, autoimmune response to virus or bacteria. That's just a picture. I'm glad we have that. That's really cute. Phases. This is important. Okay. Now, GBS, there's no real cure for it. There's kind of two ways it can go. The people who have GBS there's an acute phase, 1 to 4 weeks, where it starts from their toes and it just causes this, I think essentially it's like a paralysis, like a flaccid paralysis. Yep. Flaccid paralysis. Your muscles just literally cannot move. They're flaccid. Sucks, right? Because when that myelin sheath is being eaten up, it's been hurt, right? You just, nothing is getting through. So that central nervous system is like, can't we move? And you just can't. It can send those, but they don't get to the peripheral nervous system, or they don't get around to where they need to go. The farther ones get eaten up, and as that thing kind of travels, anyway. Paralysis, yeah. So in that 1 to 4 weeks, now this is important, in the 1 to 4 weeks, the paralysis will progress essentially ultimately. After that 1 to 4 weeks, once the acute phase is over, the progression of the paralysis ends. The paralysis, where it ends after the acute phase, is where it's ending for the GBS state, like, moment, okay? There's no easy way to stop GBS. It just happens, and you have to make sure to keep that person alive in hopes that they survive the next couple of phases, okay? That's the acute phase. 1 to 4 weeks where the symptoms start and get bad. They go from the bottom up, okay? It's important. After that 1 to 4 weeks, once the paralysis progression stops, there's a plateau phase, which can last for several days to 2 weeks. And in this plateau phase, the person is not getting better, okay? But the thing is, with this plateau phase, they might not be able to move. They can't move. They've got that flaccid paralysis, but the flaccid paralysis is not progressing. It's done. It's stopped. It's just over, okay? That's where you've got it, okay? And after that plateau phase, you have the recovery phase, okay? Why can I recover from GBS? Recovery can take time, blah, blah, blah. Body's natural healing. The peripheral nerves can regenerate and recover function over time. Oh, well, that freaking makes sense. Hey, there we go. Schwann cells aren't as easy to kill. Yeah, more likely to be able to recover. So, during this acute attack, GBS is going, your Schwann cells are fighting for their lives. And in the recovery period, that's the period where if you're gonna recover from GBS and not perish, you're eventually going to regain function. At least most function. They might have long-term issues, but they can get a lot of their function that they had back, right? Some people don't fully recover. Some people do. Some people, yeah. It really does just depend. So the acute phase, 1 to 4 weeks, that flaccid paralysis is progressing from the bottom of their toes all the way up, or how far it gets. And then after that's done progressing, the flaccid paralysis has stopped, we hit the plateau, where couple days to several weeks, you are stuck at that baseline of flaccid paralysis that you left off with in the acute phase. And then after that, right after the plateau phase, after 4 months to couple years plus, you're able to sort of start recovering. Your body is slowly beginning to build back, and you're able to, do your thing again. And some people are able to get back close to where they left off, and other people have lingering symptoms or etc. But that's usually how it goes. Okay? Possible causes of GBS: pregnancy. I mean, that's kind of rough, bro. Yeah, you're more likely to get it if you're a male, but if you get pregnant, hey, there you go. If you're old, 55, it's not old. That's not old. You're just 55. It's not old. I'm just a baby. That's why I say it. Recent viral infections, such as Epstein-Barr or the flu or something, surgery, another acute illness, immunizations, maybe being an autoimmune problem that you just have genetically. But here's the, manifestations. You have the ascending/descending symmetric muscle weakness to flaccid paralysis without muscle atrophy. So it's not just on one side, it's on both sides, and it crawls up. Usually legs first, and it's symmetric. They say descending. Can GBS cause descending paralysis? Most common involves ascending. Some cases can present with descending, starting in the upper body. And see, the problem is that is worse. Because, you know, in the upper part of your body is where your, like, lungs are and your diaphragm is. Your lungs aren't a muscle, but your diaphragm sure is. And that's a big part of, you know, what helps you breathe. So I'd rather have ascending paralysis, but we don't always get to choose. Oh, well. Decreased or absent range of motion, because you're paralyzed. Decreased or absent deep tendon reflexes, because you're paralyzed. Respiratory compromise and failure. And that has to do simply because if you're not able to properly breathe out and get rid of your carbon dioxide, you're looking at issues with respiratory, acidosis. Now, like, the common thing is like, well, if you've got that, your body will compensate. Yes, so you'll start in alkalosis and you'll get to acidosis. It's still an acid-base imbalance, though. I don't want either of those. Truly and honestly, I don't want either of them. Respiratory compromise and failure can happen. And I mean, truly, if you're not breathing, I don't care. Like, if you're not breathing, the fact you don't have any sort of oxygen in your blood will kill you faster than faster than just having too much carbon dioxide. Well, listen, I don't want either of them. Loss of bowel and bladder control, because you're paralyzed. Absent bowel sounds, because you're paralyzed. And remember, those nerves innervate the smooth muscle of your GI tract. So if those are damaged, you don't have a whole lot of function there as well. This person may have pain just because of just nerve problems, which definitely needs to be kept on top of. They can have facial weakness, double vision, and that, of course, if this is ascending, that can take a bit of time. Now, one thing you can do, and this is true for MS as well, if your patient ever has like double vision, you can always give them like an eye patch, right? Because then they don't have the double vision because they covered one of their eyes. When you say it out loud, it kind of sounds very silly, but it's very true. Like, if you have, oh no, I can see two of things. Well, what if we just take away one of your eyes? Oh, much better. True. And then monitor blood pressure. Because, hey, listen, if your bowels are being affected, bowels are smooth muscle. Guess what else is smooth muscle? Oh, your blood vessels? Wow, yeah, you're right. Now, remember when we were talking about, like a traumatic brain injury or like a brainstem injury and all that, and like issues with the spinal cord injury and everything, and how we talked about how if you have an issue where, your spinal cord has been hurt in some place, right? And everything below that spinal cord is affected, okay? Remember, that's nerve focused, okay? Even though it's a central kind of nerve thing, it's still nerve focused, okay? Everything below that area of injury can't vasoconstrict. It can't vasoconstrict. Because it is your neurons that send the message, because of the hormones and neurotransmitters that are in that synaptic gap, to say vasoconstrict, okay? Because nerves and muscles work together. Muscles don't just contract randomly on their own. Nerves do that. If the nerves are causing them to contract, that's what they're doing, okay? Even if it looks random, because your nerves are having some sort of spasm or something. Oh my word! They're paralyzed, okay? They can't send stuff, so there will be no vasoconstriction. Right? Hold on. Primarily affects the peripheral nerves. It can also lead to autonomic dysfunction, including vasoconstriction. Can manifest, hold on, why though? It can disrupt autonomic, blah, blah, blah. What about vasodilation? How does it affect, okay. Fine, I'll accept your freaking cookies. Okay, Possible blood pressure fluctuations due to autonomic disturbances in Guillain-Barré syndrome have been described in previous reports and may develop blah blah blah. Presented severe blood pressure fluctuations and successfully treated with intravenous immunoglobulin, blah blah blah. Whoa! History of hypertension, but her of around 140 milligrams or millimeters mercury systolic, but her systolic blood pressure on admission was above 200. Heart rate was normal. Also presented respiratory failure due to respiratory muscle paresis. Other general findings: pneumonia of low, blah 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 blah. Endotracheal intubation, blah 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 blah. Her dropped 40 milligrams with rapid administration of dopamine. Hypotension recovered. So the issue here is that there's not you can't really. The reason, okay, that our blood vessels need to be able to constrict and dilate based on what our nerves tell them is so that they can compensate for the changes of fluid volume that happen all the time in our bodies. If you lose that, any sort of change you make to forcefully cause that constriction or dilation, right, will be harder to fix, or like it'll be much more intense because it's your blood vessels are like, I guess we're constricting, I guess we're dilating. Pretty rough actually. Shoot, that's crazy. Yikes. That sucks. Ooh. No, yeah, okay. Interesting. Alright. Anyway, so, things to keep in mind. Diagnostic procedures. You might see an elevated white blood cell count if they've got, like, a bacterial infection, I guess. ABGs, no issue if the paralysis isn't up there. So if the paralysis ends at the waist, you're not going to have diaphragm problems. So the person might lose control or any sort of, they might have paralysis, flaccid paralysis of their legs, but they'll be able to breathe just fine. If that paralysis climbs up all the way up to their diaphragm, then they can't breathe. That'll start off as respiratory alkalosis and then move into respiratory acidosis, because that's usually how it goes. It starts in alkalosis, gets to acidosis when things have gotten really bad, if they still can't breathe. So this person may need mechanical ventilation if they don't have the ability to breathe on their own. Lumbar puncture, they'll see increased protein in the first couple of weeks. Why though? Why increased protein in first couple of weeks? GBS. Protein lumbar puncture. Thought to reflect the widespread inflammation of nerve roots. Okay. Sure. Okay. Inflammation of nerve roots, protein. I'll give them that. Why the heck not? Albumocytologic disassociation. Interesting. Elevation in CSF protein without an elevation of white blood cells. Cool. So, nerve roots be damaged. Nothing abnormal seen in the CT or MRI. That's important. Everything will look totally chillin' and fine in the CT or MRI. Yeehaw. Wow. Pulmonary function tests. These will be used to measure capacity of the lungs, such as your tidal volume. Tidal volume, by the way, is the amount of air being moved in and out of your lungs with a single breath, basically. And I'm gonna double check that because I want to make sure. Make sure I'm not just. Look at that. Yeehaw. So, in GBS, because if that diaphragm, let's say if the diaphragm is affected, okay, which it might be if the flaccid paralysis has moved up there, then your ability to breathe in and out will be affected. Your tidal volume will be decreased because your total capacity of your lungs will be decreased because you can't, breathe in and allow those muscles to kind of move and relax in order to increase the pleural, I don't know, pleural space or whatever. And then you can't really push anything out very well because you can't move up and move down your diaphragm or whatever, okay? There you go. Boom. Of course, you don't want, like, if this person is on a ventilator, you don't want to just be like, well, I'm glad that we've got them here. How about we just increase their tidal volume crazy? No, you don't really want to do that. Let me pull up, no. The one thing I don't like about GoodNotes, side note, is that you can only have one window open. That's kind of annoying to me. I would love to have multiple things open. And it says I can. Hold on. Hey, what the heck, dude? I want to see more. I want to see more. Anyway, we'll see if that even pops up. Neuromuscular. Oh, definite. What the? Oh, we're on the wrong one. I was like, what? No specific tests to identify GB. Cool. Now this goes over the cranial nerves, nursing concern. I don't know why the freak this is there. Nursing concerns for GBS. It would make more sense if that was up in MS. Anyway, I mean, listen, I guess it makes sense if we're talking about like the vagal nerve and the lower ones starting up, but I don't know, whatever. Let's move up to the nursing concerns for GBS. Guillain-Barré syndrome. Big one is an effective breathing pattern. Of course, if it's reached their diaphragm, they can't exchange gas effectively, causing them. I mean, that's going to kill them first, compared to all these things. Impaired physical mobility. They can't move. They're at a risk for a bunch of different things, specifically tissue integrity. Impaired tissue integrity for sure. They're at a potential for a pressure injury. I would say that pain needs to be up here as well. I mean, it can, right? They said it. They said it. May have pain, should be controlled. Whatever. Powerlessness, yeah, definitely. It's a psychosocial issue. Risk for DVT, yeah, that's a big one. Listen. Hey, could they get a DVT? Yes. Do I want... No. In fact, if they get a DVT and then that turns into like some sort of embolism and heads up to their lungs, we've got a double problem. Not only if their breathing pattern already like affected and they have impaired gas exchange and they're not able to like really breathe very well. Imagine you add a pulmonary embolism to that. Oh, that sounds like a nightmare. That's awful. That's terrible. Ugh. Okay. Altered elimination, bowel and bladder issues. This person during the recovery period will definitely need to go through bowel and bladder training to regain that sense of control, as well as, regaining that idea of how to even go. But during the plateau phase, yeah, being able to say, kind of do it on a schedule is probably the best way to go, just so that person can, I would say, have a semblance of being able to kind of get back on track. Because remember, all those smooth muscles, they're also innervated in the peripheral nervous system. So I guess the question that I have, right? Yeah, I mean, how is cardiac muscle different? Because I know it kind of runs on its own. Is the heart affected by GBS? Yes, it can affect the heart, causing arrhythmias, unstable blood pressure, and in rare cases, heart failure. Yeah, okay. I was about to say, it can affect the autonomic nervous system, which controls involuntary functions like heart rate, blood pressure, and digestion. It can cause irregular heartbeats, including both slow and fast rhythms, stable blood pressure, heart failure, Takotsubo cardiomyopathy, where the heart muscle weakens, triggered by sweat, which has been Huh. I mean, that makes sense. It would make less sense if it didn't have any effect on the heart, because everything is innervated. Is there anything that isn't? Maybe your weenus? Body that is not innervated. Some areas like the visceral perineum itself and the brain are not innervated, so although they do have nerve endings for other functions. PP. Hahaha. It's interesting. Anyway, it's not relevant. I was just curious. Anyway, GBS treatment. All right, here's the important thing. GBS is not like a progressive, like it is progressive for like 1 to 4 weeks, and then it's not progressive anymore. It stops, kind of. So corticosteroids in stopping inflammation. Hey, where's the inflammation though? Like, this is not caused by like stress. This is caused by something. It's just caused by your body saying there's some sort of immune issue, and then that's like, why don't they freaking help? I'm curious. Why don't corticosteroids work GBS? It might worsen muscle function. Consistently shown, whether given alone or in combination, do not help or significantly improve recovery. Might even delay responses. Okay, why? May have a negative effect. I asked why Google Gemini. Hey. Why do steroids not work? The drugs have a harmful effect on muscles, which counteracts the benefit of reducing inflammation. Okay, so it's not that they don't reduce inflammation. It's just that they will make it worse. That sucks. Dang. Because, yeah, the way that GBS works, it almost does look like it is this... It almost is like an infection process. But it's like really bad, you know? It's like an infection process where there's some sort of issue affecting and attacking your Schwann cells and your myelin sheath and your peripheral nervous system, and then eventually it stops. Eventually it just stops, right? And your body has to recover. But if part of your body recovering includes, I guess, your immune system, as usual. But it's so interesting. Yeah, that's really interesting. Drugs have a harmful effect on muscles. Crazy. Hasten recovery. Huh. Interesting. Huh. Okay. No corticosteroids. Corticosteroids, they're fine for MS, not for GBS. No corticosteroids, no prednisone for you. Plasmapheresis. Okay, so plasmapheresis is an exchange of plasma that is done. It's kind of like dialysis, but for your blood plasma. It essentially switches out your crusty, dusty, bad plasma with good, clean, brand new plasma. And a person with GBS who wants to kind of get this treatment will have either plasmapheresis or IV immunoglobulins, okay? And I remember I looked this up and why would overtaking this. Okay. I looked it before. You might choose plasmapheresis plasmapheresis over intravenous IG, which intravenous IG is really kind of similar, except that it is this immune system suppressor, sort of, but IG is like a normal thing that pops into our body. Like we are supposed to make it ourselves. And it's IV, it's faster, it's easier, it's cheaper than plasmapheresis. But the reason that you might choose plasmapheresis over intravenous IG is if you have a condition where pathogenic antibodies are causing problems that need to be removed quickly and effectively. Yeah. So in conditions such as Guillain-Barré syndrome or myasthenia gravis, you're more likely going to want to have that plasmapheresis because this is caused by pathogenic antibodies. So then you can say, hey, let's get rid of them. Let's just take them out of the plasma. Let's get brand new plasma in there that's not going to freaking eat up our sheaths. Yeah. Cool. That's actually so interesting. Yeah. Huh. Antibody reset moment. Very cool. So, IVIG might be preferred if you have an antibody deficiency, because your body is supposed to make IVIG on its own, or I guess IG on its own, but here you're just getting an infusion of it, which can help with primary immunodeficiency disorders. It can also help to modulate the immune system in autoimmune diseases. So although this is faster, plasmapheresis will often get more of the job done when it comes to GBS and myasthenia gravis, which we'll talk about soon. You can treat pain with gabapentin. Gabapentin is a I think it's a... Oh. It does work in the central nervous system, though. What the crap? I'm sorry. Gabapentin. Anticonvulsant nerve pain medication can treat seizures. No! It's an anticonvulsant. Okay, that's nice. Mechanism of action. Binding sites throughout the brain. Yeah, it does work in the brain. Haha. Alpha 2 and whatever that one is. I'm sorry, I never learned Greek. D. Delta? Alpha 2, Delta 1. Sure, buddy. Voltage-gated calcium channels inhibiting the release of excitatory neurotransmitters in the presynaptic area that participate in epileptogenesis, seizure creation. Anyway, opioids if pain is not controlled with gabapentin, and heparin to prevent a DVT. We don't want a DVT. So plasmapheresis, okay. Plasmapheresis. Let's look up why can plasmapheresis cause hypocalcemia. Plasmapheresis can cause hypocalcemia because the citrate-based... Again with the citrate-based! Guys, hey, I was about to be like, oh, well, you remember how if somebody's really receiving a lot of blood, you want to be watching out for hypocalcemia with tristos and schwarzkopf because of the thing. But I was like, no, it couldn't be that. Well, here I am remembering that, oh yeah, plasma is a freaking blood product, and so is IVIG. Let's think about that. What the heck? What the crap, guys? And apparently they freaking use these citrus-based anticoagulants as well. So here we go, people. Here we go again. Trousseau as in, I like to think of it as tetany, okay? And the classic, tetany kind of picture. One of these. So, in Trousseau's time, if you have that blood pressure cuff, and you kind of slowly inflate it around the person's arm, they're going to slowly bring their hand kind of into this position right here. Boom. Okay? That's Trousseau's shine. And then schwarzkopf is CH for cheek. So if you tap them on the cheek, they'll kind of twitch. They'll twitch. Do they twitch on the side? Yeah, they twitch. Look at that. It's the same picture. That's hilarious. They twitch on the side that you tap. Just like that. And here's the plasmapheresis thing. Woohoo! Separation of plasma from whole blood, after which the blood cells are returned to the patient without the plasma to eliminate the antibodies. Okay, cool. So yeah, you can have an allergic reaction to this, of course, because it's a blood product. Medications to prevent complications. Somebody, like antihistamines, corticosteroids. I don't know if you would. In the case of this person, sure, analgesics, anticoagulants. The citrate is pretty. I mean, the citrate's in. You know what? Whatever. Whatever. Watch for hypertension, tachycardia, fever. Big one is definitely going to be those signs of like allergic reaction. If you see those, any flank pain, any tachycardia, I'm freaking out. Stop it. Stop everything. Stop it. Don't do it. Monitor for signs and symptoms of fluid volume deficit, bleeding, impaired tissue perfusion. If a patient they come in, you'll check their medical history, check them for flare-ups, new symptoms. If they've had a plasmapheresis before, check their meds, IV access, consent and understanding, post-procedure. I think there's a group that did a thing on this. Paralysis, immune disorder. No, they didn't have one. Hey, I remember they didn't have one. I'm firing them for that. Anyway, there's a plasmapheresis video that they didn't show in class. Complications: hypocalcemia, yep. Urticardia, which is itching or hives. Itching is interesting because urticardia, let me look that up. Urticaria in plasmapheresis. Yeah, I forgot. I definitely have safe search turned off. LOL. Anyway, occur as a side effect during plasmapheresis, a preserve blah 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 blah. While sometimes effective for removing certain substances, can often trigger allergic reactions. What the crap? Hey, I'm looking. That's terrifying. We would stop it. Get out of here. Itchy, raised welts on the skin, common side effect. What the heck? What do you mean common? Hey, what the heck? So how? Okay. Hypersensitivity. So if you've got itching, redness, anaphylaxis, stop it. Stop everything. But if you just have itchiness, I guess how about we ask why? I'm like a 3-year-old when it comes to this. Contains antibodies, or histamine release. Okay, so it's the okay, I guess histamine being released because it's got antibodies in it. So the antibodies are like, oh boy, I'm so excited to be here. Let's get started, and they have one right away. That's interesting. The procedure itself causes the release of histamine, a chemical that is involved in allergic acid. Okay, so it's the fact that during the plasmapheresis, histamine is released, which causes that itching. Okay, that makes a lot more sense than just, well, it's an allergic reaction. I don't like allergic reactions, though. Okay, depletion coagulopathy, which is blood clotting issues. Factors located in the... Okay. In the plasma. Boom. Boom. Okay, so if you're taking out somebody's plasma and putting it back in, there's a chance that maybe they lose some of their clotting factors. So it's depletion coagulopathy. Because you're losing... There we go. Fluid shifts or depletion. Monitor post-procedure for fluid volume deficit. Risk for infection, because you are just getting it all up in there to replace their plasma. Site-related related issues such as infection, phlebitis, or clotting, and that's at the site, so wherever they're doing it. And then here's IVIG, which is our highly purified immunoglobulin G derived from large pools of human plasma. Thinking about that without any context that we're not this dystopian civilization is So funny. I'm just like, you know, like freaking like breeding pools or like tadpole pools, and it's just all this human freaking plasma. That's kind of awesome. Sci-fi wise, I'd watch that freaking movie. That probably exists in the Matrix. They contain antibodies against a broad spectrum of bacteria and viral agents. IVIG. So complications. Hey, it is a blood product. It is a blood product. It can cause anaphylaxis. It could also cause aseptic meningitis. I don't like. Those are all bad words. If those are, don't ever catch me wanting any of those things for myself or my patients. What is so aseptic meningitis? That's an inflammation of your meninges that's not because of anything. Why aseptic with? Okay. Contains certain stabilizing agents may directly irritate the meninges. Oh, that's nice. Cytokine release can trigger the release of inflammatory molecules that can cause a meningeal inflammation. So similarly, I guess, to the plasmapheresis causing the release of histamines, it causes this release of the immunocomplexes, cytokines. That's not a complex, they're just cytokines. Just cytokines coming in and being like, and tickling the meninges, being like, oh yeah, you like that? Well, you really do? Well, why aren't our antibodies good enough for you? Oh, they were eating the schwans. And then they suffocate them. Retinal necrosis. Oh, that's nice. Hey, why are my eyes dying? Retinal. Okay, might be used. What? Death of the retinal tissue. Oh, that's nice. That's so cool. Why can IVIG cause? Therapy generally safe. In rare cases, it can cause retinal vein occlusion. Well, of course that would cause your freaking stuff to die. That's nice. That's really interesting. Can cause hyperviscosity syndrome, where the blood becomes thicker, leading to blockages in blood vessels, including those in the retina, which can cause retinal vein occlusion. I guess because those veins are really freaking small. Dang. Well, that sucks. And acute renal failure. Primarily due to osmotic damage in the proximal tubules, often associated with sucrose-containing formulations. What? Sucrose-containing? How do they make the sucrose? You know what? It says it's rare, right? But kidneys are not able to metabolize sucrose, which is a common stabilizer in IVIG preparations. Well, that sucks. When sucrose-containing IVIG is administered, the sucrose is filtered in the glomeruli but not metabolized, which leads to an accumulation of that in the tubules and causes damage because they're like, this was supposed to be gotten rid of, and it's like, but we can't do anything with it, which causes tubular obstruction and impaired renal function. You're more likely to get this, of course, if your kidneys have already been fighting against kidney disease, diabetes, older age, dehydration, because your kidneys are like, please, I just can't take any more of this. Undesirable effects occur at less than 5%. So this is really rare. We don't get these a lot. And so they'll usually give a pre-treatment of acetaminophen and diphenhydramine, which is Benadryl, to help with those anti-inflammatory effects. Yay! Medication information. Heparin for DVT, gabapentin to prevent for pain, opioids for double pain, diphenhydramine to help with immune response, and anti-anxiolytics because this is terrifying. Yay! Okay. So that's kind of it for multiple sclerosis and Guillain-Barré syndrome. Yay! Good job, everyone. This is really fun and really cool. I need to get some orange juice because my throat freaking hurts. Because I've been talking for probably an hour and a half. Actually, maybe more. Anyway. anyways, see you in the next one, I guess.